step is very essential, and you can appreciate that we have made the prostate attached only to 9 o'clock, and at this stage we cut the mucosal band which is there at 9 o'clock position, and once we have cut this mucosal band, now the whole adenoma is attached throughout its length from viru to bladder neck at say 9 o'clock position, and we will work clockwise and counterclockwise, and you can appreciate nicely this is the adenoma. We have gone all around the adenoma, and the attachment is virtually at 10 o'clock and 9 o'clock. Now this is the attachment virtually at 9 to 10 o'clock, and we will work our way on the capsule. The two areas which are defined are at say 10 o'clock, and this is at 9 o'clock. So this is how the process of enucleation is getting completed. We have enucleated from the top, we have enucleated from bottom, and this is the only area which is attached. And as I was telling you, see, these are the capsular fibers all along the length, and this is the only attachment which we will do away with. And as I was saying, that throughout this enucleation you can appreciate there is no bleeding, and this causes no hemodynamic disturbance throughout the procedure. And as I said, this is very good for high risk patients, patients who have very poor ejection fraction, patients who are in failure, they can also be taken up. And we have done patients who have 15%, as low ejection fraction as 15% have also been taken up for this enucleation procedure. The two things which are very important in prostatic enucleation, one is it can be done in high risk patients. The other thing which is important is a completeness of the job, because when we enucleate all around the gland, and we are able to achieve a complete removal of the adenoma. We have now 10 years follow up with us, and I presented this follow up in the Chicago World Congress of Endourology, and in this we invited all the patients which we have operated from the year 2000 onwards, and this data reveals that these patients have very low truss volumes even at 10 years. We had more than 150 patients who were having a 10-year follow-up, up to 10-year follow-up, and the data was that the PSA was around 1, and the truss volumes were around less than 10 grams. So that is the advantage, that durability of the procedure. Other advantage is safety of the procedure. And the third thing is that because it is complete enucleation, you have good quality voiding. What is more important to do in a benign disease is that when earlier we used to do NDAG, the patients used to have poor quality voiding, poor flow, dysuria, but nowadays when we have started doing HOLeP complete enucleations, it gives you a very good quality voiding. Patients have peak flow rates even higher than 50 Qmax. So that is where it scores urodynamically over any other method of prostate reduction. Now this is just as I said, that this prostate was slightly sticky at 5 to 7 o'clock position near bladder neck, and we were having some difficulty in finding the plane at say 7 o'clock position. Here again the aim was to prevent any kind of injury to the right ureteric orifice. As you must have noticed that in the beginning we were not able to define the right ureteric orifice, and see how precisely we are able to define. See, this is the bladder neck, and I am trying to go around the adenoma at this point. These are the capsular fibers below, and we will very precisely cut this area, and at this particular point we will be able to reach to the capsule, and then we will be able to work our way from say 7 to 8 o'clock and 8 to 9 o'clock without causing any kind of concern to the right ureteric orifice. Another advantage of this procedure is in Indian circumstances is the reusability of the fiber. You will appreciate that this fiber hardly 4 to 5 mm is used in one procedure, and the fiber length is around 3 meters, and we simply cut, we don't have to cut, it gets vaporized on its own, and this fiber, you see, is hardly consumed throughout this procedure. And I have personally done more than 200 cases with one fiber, though we do not recommend that kind of a thing, because initially when we were learning HOLeP, we have wasted also 2-3 fibers in a case, but now as we have gained experience and expertise with one fiber, we can do. So I recommend that around 40 cases can safely be done with one fiber, and that makes it very economical in Indian scenario, because one fiber is costing say around 30,000, but if you use it in 30 patients, so the maintenance cost or the running cost of this procedure should not be more than 1000 rupees, Indian rupees. The one morcellator blade is also reusable, and we can do 40 to 50 cases with one blade. So that is how that if future of this procedure is very promising, especially in a country like India, where we are looking for economics, we are looking for poor patients. And see now what we have done. We have enucleated from below, we have enucleated from above, and this prostate is only attached. See, this is the veromontanum. From vero, the capsule is exposed all around, and we have at 12 o'clock and at 6 o'clock all exposed. This is the only attachment near the bladder neck at 9 o'clock, and at this particular point we will again work on the capsule. That is the hallmark of the enucleation, that you always stay on the capsule, work from a defined to an undefined area, and we are sort of working in the same fashion in a clockwise and counterclockwise movement. And during this movement the prostate gets enucleated, and now this is the only attachment at 9 o'clock. And if you see, within just 1 or 2 minutes we will be able to throw this lobe into the bladder, the whole thing, the whole right lobe and the middle lobe, and only attachment. Now this is the floating lobe inside the bladder. This is the prostate fossa, this is the area of previous resection, and you can appreciate this is the apical tissue. On the left side, the previous surgeon who has done TURP, he has left this tissue on the left hand side. This is the adenomatous tissue, which sort of at times regrows, but in our experience we have seen we get lot of such patients. I have done now more than 70 cases post TURP residual prostates. In a country like India, people do take up large prostates for TURP, and when the patient starts bleeding or starts having rigors, they sort of stop the procedure, and sometimes the surgeons, they do one lobe only. As you see in this particular case, only one lobe was sort of resected by TURP, and that too you have got this apical tissue left. And so I personally feel that TURP does not do an adequate job except for very experienced resectionists which are able to do the job fast, and therefore TURP should be done only for glands less than 100 grams. If the tissue is more than 100 grams, one should not venture on to TURPs. But this size limitation is not a factor with holmium laser enucleations. Any size of prostate can be safely enucleated. We have done up to 300 grams prostates, safely enucleating them, and that is the beauty of this procedure, because you can appreciate that once you are on the capsule, no blood loss, you can simply keep on working and enucleating. This is the apical tissue which was left by previous resectionist on the left hand adenoma, and now we have found the plane behind this residual apical tissue, and we have enucleated this also. Now I will just show you how the fossa looks like. You can have certain tags of tissue onto the fossa, and these tags can also be vaporized with this laser. This 100-watt end firing this fiber is very good for that vaporization also. Now this is the beauty that it has got enucleated this. Now this is what I was mentioning, the vaporization of the tissue. So you can have little bit of tissue here and there. These are few tags of tissue. Now we have sort of vaporized them. This is the process. The other thing which we have to see at this particular stage is the hemostasis. This is the viru. See how extended viru and how much is the tissue distal to viru. Now this is all few tags we will remove, and this is the tissue. See the extended stretched out veromontanum, and this is the sphincter. So you can appreciate that the sphincter is intact. That is again very excellent demonstration of the enucleation technique, that you do not injure the sphincter, and all the tissue which is hanging here and there can be vaporized. The good point about this laser is that it is now time tested. For more than 10 years we have been doing at this center, but all over the world for more than 15 years this holmium laser has been used. Now this is the vaporization which is going on all around the fossa. See, this is hardly any tissue which is there. You can see the capsule all around the fossa, and the beauty of this procedure is that you see the capsule all around. This is the small tags which can be sort of enucleated even in a second look. Now we are having a second look. This is small tissue which is left at 6 o'clock, which again I am enucleating. And with the kind of fossa we get, there are two things which are excellent about it. Is that the urodynamic results post-operatively are very superior, as good as open prostatectomy. And the good point about the whole thing is that this is the time tested technique. Now we are doing it for more than 10 years at this center, and we have done it all over the world. It started in year 1996 onwards. So practically we have an experience of more than 14 years of this procedure, and more than 14 randomized controlled trials have been published on this procedure, and they all document its safety and efficacy. And this procedure, after this procedure, patient can be sent home either the same day or the next day with a catheter. Catheter can also be removed safely within 36 to 48 hours. The other good point about this procedure is that no tissue is lost in histology. For this vaporization procedures, the tissue is lost in and not good for histology. But here you see the whole adenoma has been enucleated and thrown into the bladder, and we are going to remove this by morcellation. We will just show you how the morcellation works. But the morcellation is a procedure in which we cut this adenomatous tissue into 4 mm by 4 mm pieces, and this is as good as any histological. Rather, you can have some charring in the TURP pieces because of the diathermy artifacts, but here, because it is cut by mechanical cutter, you have got no diathermy artifacts, and the tissue gives you absolute histopathology. And as I said, that because there is no bleeding, there is significantly reduced catheterization time, significantly reduced hospital stay, and now we have more than 3000 cases done at our center, and the data reveals that these patients can be sent home early with no need for blood transfusion and no need for repeat relook surgeries or clot retentions causing problems.